what I want to talk about today is to give you a little bit of information about our journey, a little bit of information about Nova Scotia, and our context for those of you who don't know about us, kind of why we went down this path, a little bit of information about the project itself, some of what we've learned in the time that we've been using the system, and just give you a little bit of a glimpse from my perspective of where I think we want to go next. So Nova Scotia is one of the provinces in Canada that's on the Atlantic side. We're that little red dot on the far right. The picture on the left is Peggy's Cove, which for tourists is one of our primary sites where people want to go. Nova Scotians just consider it a great big rock. I think it's quite spectacular. And the picture on the bottom is Halifax, which would be the capital city of Nova Scotia, and the area where we have all of our tertiary services. Small population in context in Canada, just under 1 million people, and that population is split almost a third in Halifax and a third towards a half, going on the half, and the rest scattered around the periphery of the province on the outside. So this is a map of Nova Scotia. It has changed. If I would have been giving this presentation prior to April, there would be 10 different pockets in the map with different colors. We were merged in April 1st. Prior to April 1st, we were 10 organizations providing services, health services for the province, and we have a regionalized system. And so the health authority is responsible for the delivery of all health services across the spectrum. So we have responsibility for community-based services, public health, home care, continuing care, primary care, hospital-based services, and long-term care, palliative care on the other end. Whole spectrum. The only difference is when we were all merged, we were merged into one organization with the exception of the Children's Hospital, which is separate and operates completely on its own. And so you can see all the little dots. Those would be our health facilities that are all kind of scattered around the outside of the province. We have 35 sites, and across those 35 sites we run with 3 different health information systems. 2 of them would be in Halifax, so our tertiary quaternary service is largely on its own with a couple of hospitals added to it. The Children's Hospital has its own, and everyone else is on another one. Kind of a strange situation to be in, but that is currently our reality. So why did we go down this road? Like, you know, from what I've heard from people that I've talked to since I've been here, the presentations before, I think we all have some of the same situations going on. You know, for us, we lacked any comparability of any data that we had related to patient flow and utilization. It was very difficult to use the information to make any sort of a decision. It wasn't timely by the time it was on paper. It was all on paper. It wasn't accurate anymore. It didn't mean the same thing. We had more than 10 ways of collecting our utilization information. We had variability, significant variability in length of stay. Care planning, if it actually happened in some of our facilities, was variable. Our hospital admissions were all over the map as far as appropriateness, but we didn't actually have any evidence that we could use to be able to say how bad the situation was, which facilities do a really good job of what they're admitting, which ones were really bad. It was all really innuendo and assumptions. We had issues with transitions in care, and the other thing that we had gone down this path for about 3 years before, where we had done a lot of work on moving forward interprofessional teams and looking a lot at populations at a unit level and making changes to skill mix but there was a real lack of ability to compare those because we had run into the same issues. There was no system that had consistent information that we could compare site to site and organization to organization. We had health system gridlock. We had issues with offloading in our emergency departments. Halifax has always had issues with 20 ambulances lined up, and what Nova Scotia has a provincial ambulance service that is all one system. And so when Halifax gets gridlocked and all the ambulances are parked outside the emergency department, they move them from the periphery in. And so we had communities in the periphery that had nothing because our ambulances all had to be moved where there was more likely to be a call. And so it really left us with this need to do something different. And largely those issues were all because we had backups in emergency departments, we didn't have people in the right beds. And so our project, we chose in Nova Scotia to take a different path than the clients that we had spoken to when we chose to go forward with Medworxx. We implemented one system-wide. So there's one installation of the Medworxx system that runs in all 35 sites. It has standardization of rules, no customization by site. We didn't allow it at all. We actually built the whole system from consensus with 10 different organizations. It took months, but it was worth it. All of our information means the same thing everywhere. We have the same processes of how we use the system, how we put the data in. And our hospitals range anywhere from 4 beds in some small little rural place that's isolated to the tertiary quaternary center, which is 864 beds in Halifax. We heard lots of things when we were moving through the process. We're different. We can't do it that way. In the end, when we got through it all, that was absolutely not the case, and we haven't looked back. As I said before, we had a real complexity with having to try and have the system speak to 3 different HIS systems at the same time. Every time we made a change, we had to retest it 3 different times because one change would impact one of the others. It took a fair amount of time to get it to happen. And when we first implemented, we implemented MedSurg first. And so we've implemented several of the products. We chose to implement because we implemented version 4 initially. This process started in 2011, and our first site went live in 2012. And so we started on MedSurg. We then went to ICU. And so what we did is we implemented the MedSurg criteria set across all 35 sites. And then after that was done and stable, we implement ICU. And in ICU, we implemented it in the tertiary center and all of our regional hospitals. And then we implemented postpartum newborn. That turned out to be a futile exercise because we actually found that and I don't know why we made the decision to implement it in the first place. I think the Children's Women's Hospital wanted it, yet now they say they didn't. It was an interesting kind of phenomena. We found that we didn't have a utilization issue, and we were actually, because we'd made so much progress in how we delivered that service, we were sending home MET people. And it just didn't make any sense to keep using it because there was nothing to track because we didn't have an issue. So we have it, it's built if we ever need to use it, but we made a decision to stop using it. And then we went forward and implemented mental health. Our clinical criteria is licensed for 1,500 beds, and we then implemented the bed management system, but we implemented the version 5 system, and it's licensed over 3,000 beds. We also, as part of our project, set 25 KPIs that we determined before we actually started the project. So we had a really good baseline. Our project was funded by an innovation grant by the provincial government. And in it, it had a return on investment. And so in order to get the money, we had to promise them that we would actually be able to make a difference in the system and recoup money. And so in year 3, we had to hand over $3.5 million back to government from our funding, which would have been the savings that we were to achieve with the system. The unfortunate thing is they wanted the money in the timeline that they thought it should happen rather than in really the timeline that made the most sense with the system being stabilized. And I'll go through some of those KPIs in a couple of minutes. So the model we use, like all of you, we do a daily assessment. And our assessment model is direct care provider. And so in Nova Scotia, we have registered nurses and licensed practical nurses, or in Ontario, RPNs. Both groups of professionals do the assessments. That largely has worked okay for us. The one thing that it did have an impact is we have 6,000 staff who are assessors in Nova Scotia, which gives you some context to the data quality challenges and commitment that it takes to kind of crack that nut. We also set a standardized time, and so all of our assessors, they have to do their assessments. It has to be after 12 midnight, and they have to be all complete before 12 noon. And we've made a decision system-wide that we would do them on the night shift just prior to shift change, so that in the morning when the day staff came on and the doctors started doing rounds, all of those assessments were all current. Then we didn't have issues where they were doing rounds before the staff had had a chance to do them, and they're going by the day before's information. We've had a couple of units that have changed that and moved that into the morning, but largely across the province that process has still happened. And the reason we chose to go with the frontline staff nurse doing it is we felt they should be the most knowledgeable person at that given time about what the needs of that patient are and what the plan of care for that patient is. And one of the other factors that led us to do this is we had done 3 or 4 years of work on, like I said, this interprofessional collaborative team project, and in that was very much moving the scope of practice of the registered nurse to where it should be, is that core individual to help move the plan of care forward. And we thought that by having them participate as the assessors, it would force that function with their role, which they tended to want to give to the discharge planners. It has had an impact with that. Because we have 6,000 people that are doing assessments, data quality was something we put a plan in place very quickly. We set up a process where every unit has to do an audit of their daily assessments. So 10% of their assessments, they do need to do an audit every month. Those audits have to be compiled and they have to be sent to a centralized office that leads the project. So Ian and Nicole get those reports. And we also set a compliance standard of a threshold of 90%. And so any of the units that fall below that 90%, we monitor that so that we can help them bring that back up and report that. And then we created a standardized assessment tool for doing our audits so that everyone was auditing them the same way, and so that we could track the information and use it. This is it. It's in an Excel spreadsheet. And basically what they do is they would do an audit to make sure that they've met the thresholds, and then they send it in, and What we have found since we started doing our audits is our met versus not met is highly reliable. Very, very few sites when we've gone back and audited that we have found that there's any concern really in our data quality from a met not met ratio. Our RFDs, those assessments are highly reliable as well. Where we have some challenge is the specific not met reasons, where they've kind of picked the wrong one, a little bit of confusion about which one means this. And so we track those, and what we do is once we see patterns, we send out common error documents to the site so that they can share those with staff. And then Nicole has also done some education province-wide when we have significant patterns with using the wrong ones. And one of the other things that we have seen with our audits is the units that have chosen to incorporate the use of the clinical criteria system into their bullet rounds have highly, highly accurate data. It has made a massive change in the quality of their data from a reason and detail perspective. So this here is just a sample of our baseline information. We had to build into our plan an evaluation component for government. And so we did set some baseline information that we wanted to track to see whether we'd actually made an improvement after we implemented. And as you can see across the top, those are the 9 different organizations that were restarted. It's a lot easier now because there's just going to be 2 columns, the IWK and everyone else. The one thing that we made sure when we did this is all of the organizations took the same source for their data collection. We ahead of time determined what the methodology was going to be used so that it was measured the same way, and we'd made sure it was the exact same information that meant the same thing, so that when we evaluated it after, that we didn't have any issues with data reliability. We also set some indicators that we measure on a quarterly basis. As a kind of a governance model in Nova Scotia, before we were merged and we had 10 different organizations, we had set up a provincial committee as kind of a overarching governance for the system so that we could make sure that we maintained our standardization. And after we merged, we turned that committee into a provincial access and flow committee with the purpose of actually reviewing the data, and we changed the membership. And so individuals who participate on that committee provincially are high-level decision makers within the organizations, including the IWK, the Nova Scotia Health Authority, and 2 branches of government that would be, the Department of Health and Wellness and the Department of Community Services, so that we can actually start to look at the information and recommend policy decisions to government, but also so we can make more prompt decisions with how we use our resources within the health system and respond to what we're doing. And so we're very much using the data, and I'll show you some examples of some of what we've seen. We also have representation from primary care, mental health, continuing care, and public health that sit at that table, because we're very much looking at it from a whole health system perspective and not just an acute care perspective, because as you guys all know, when you look at the reason and details, largely the problems that we have are because we don't have the right resources in the right place in the community that's allowing people to go where the care that they need is probably most appropriate. One of the other things that I thought that I would also mention is because we had a government grant to implement our system, the government wanted to make sure that we met the obligations of our agreement, and so they actually had a third-party consulting group do an evaluation of our project. And it was an interesting process. We had to give them a lot of data, and they made a lot of assumptions on it, not really having a good understanding of what it was. And so no one at Medworxx would be surprised with this. I challenged them a lot. And it was an interesting experience. But the one thing they told us is our targets were too aggressive, and that they felt that he's laughing. Yeah, timelines probably were too. That they felt that we needed to take a more reasonable stab at trying to make a change. That they certainly recommended that it was an initiative that should not stop. They told government that it was well worth the money that they put into it, that we were making a difference, and that it would be a mistake to not continue, even though we hadn't necessarily met the financial targets that they had wanted. And I need to clarify that. While we may not have saved the dollars with the system that we had intended, government took the money anyway. So we had to find it in other ways, but they couldn't necessarily equate some of those savings to our improvement in use of beds. And the other big thing that they said in the evaluation is the previous districts that we had out of the 10, the ones who had the poorest performance were the ones who had the poorest engagement of their senior leadership team, and that there was a direct correlation between success and engagement from bottom to top. So what have we learned? The use of the system has had a significant impact on improving frontline staff engagement in a number of processes. Certainly, using the reports in the system for handoffs, it's had an improvement in communication from shift to shift. As an example, they used the patient list by bed unit report to hand over from shift to pass information on, certainly helping us to identify barriers to discharge and to quantify them so that we can use the information from a system perspective in how we plan future health services. We use the expected date of discharge more as an ability to look at what the potential discharges is, and we adjust them as the care needs of the patient change. We had initially planned to use the expected date of discharge and expected length of stay information in the system, but it chose to not focus on that so much, focus on the day and deal with the issue of the day. But one of the things that we found is by not trying to use the expected date of discharge, we were having a hard time to get some of the poorer, some of the physicians who maybe didn't manage their time the best to actually come and actually write discharge orders. And by using that expected date of discharge, it was prompting them to be thinking, okay, maybe I should write the discharge order on this patient tonight, knowing they're going home tomorrow, and because I know I don't do rounds until 5 o'clock in the evening, that will actually have an impact on the system. And the other thing that we use is we use the comment section in UM primarily because we want to track all of the issues that are impacting that person's delayed stay, and not just the primary one of the day that you would select in the UM status. And so we do use the comment section there to track kind of a number of issues to help coordinate the overall plan, where the staff would be focused more on that issue of the day related to the assessment. From a system perspective, I think some of what we've learned, occupancy has been a real interesting discussion. In the past, we used CIHI data to monitor our occupancy. In Canada, that's a national health information body that all of the hospitals feed our information in. And in the national standards, you're not allowed to have an occupancy over 100%. And so it really was not reflective of the actual. And so in the bed board, or the bed optimization system, we actually do allow the units to report occupancies when they're over census. And it actually has made a significant difference in having an understanding of what the real world situation is on the units. And the other thing that we've been able to use the data for is system level planning. You know, when you've got a system that'll tell you information across the whole province, that means the same thing. It certainly has enabled us to know where we need to focus our resources. But it has also been very good from a care perspective, looking at local process. System-wide barriers certainly has told us a lot about that. One of the things that it has confirmed, some of which we knew, we had facilities that were underperforming as far as length of stay. We could better utilize our resources, and that we need to shift resources from the facility side to the community. And now that we've got a lot of data to be able to tell us that. One of the other things that has been a really interesting learning for us, we had one of our zones, or one of the previous districts, who had implemented a system for tracking acuity and workload. And so we had nursing staff who were having to fill out their workload templates and do these assessments. And so what we were finding over time is the workload assessments were getting done less and less and less, and the compliance for Medworxx was very high, because they believed that the reports in Medworxx were more reflective of the acuity of the nursing units than the workload reports were. And so we've actually stopped using them. And we use the data in our Medworxx system as more of a reflection of the actual work demands on these nursing units. So just to give you, the next few slides are really to show you some of what we've learned from a data perspective. These would be our 6 hospitals in the province that have the highest percentage of RFD. So just to kind of give you a sense of it, all of their compliance is above 80. So one could be relatively confident that the data is fairly sound. We have done evaluation of it, and out of all of their patient days, all of them are in the 70% plus that are RFD. One of them, that little yellow one, occupancy is 50. The reason for that is that one facility is stretched way out at the far northern tip of Cape Breton Island, and in the winter it can be quite isolated. And so it's one of those ones that we know we just have to leave there, and it's never going to be efficient. But every one of the rest can be something else. This is just another snapshot of the same thing. So this would be 50% of our facilities. The 3 lines that are kind of in that pink are 3 of our poorest performers for compliance. Their data at that time was kind of bunk. And all of those ones in dark red were all facilities that we thought, we need to take a closer look at them, because they're facilities that we probably could do something different with. Do they actually provide a service that meets the needs of that population in the way that they are? Should they be something else? Should they be there? And so this is some of the information now that we can look at from a full system perspective. And the nice thing is it gives us information that doesn't care where something is. It doesn't have a political motivation, and it takes some of those concepts out of the discussion. Just to give you a snapshot of our reasons. So these would be our 4 management zones in the new organization. Those, in all 4 zones, those blue boxes would be people who are waiting or being processed for long-term care. And just to give you a sense of that, in the western zone, it's just under 10,000 days. Northern zone would be about 2,780. Eastern zone 6,420, and central zone 6,584 days. And that would be a period from January 1st of 2015 to May 31st of 2015, 1 quarter. So this gives you an idea what it looks like provincially. So just to give you some context, the long-term care box, 171 beds a day. There's people that are either in process or waiting long-term care. Nova Scotia, we have one of what I would say is a problem, is we don't have a really good system that enables aging in place. And you're either at home on home care, or you got long-term care. There's not a whole lot in between, and it results in some of this. Activation, 77 beds a day, and largely that is waiting for rehab beds for people with a stroke. Maybe they have fallen, fractured a hip, need some a longer rehab to be able to be back independent. On some occasions, person with a hip or knee replacement that requires a little bit of extra time. The green is 22 beds a day, and that would be largely people who are on IV antibiotics that don't need to be in hospital, but that there isn't a really good service delivery or coordination of care in home care in order to deliver that in the best way. And there's the rural issue as far as the delivery of that as well. 20 beds a day for people with wound care needs. It's quite telling. And that's just in one quarter. That's a whole regional hospital that could be gone if we actually managed that care in a different way. This is a sample of how we send the data back to the units on a regular basis. And so this would be an example of a unit's RFD days for a quarter. And we would send this to them and go, this is what the data is telling us, and we would give them an opportunity to tell us what the story is. Is there something that's had an impact on that has a local context? And we would let them do that before this gets rolled up to the Provincial Access and Flow Committee. And so it certainly has helped them to be able to show the staff, this is why you're doing what you're doing. And it also enables them to be able to impact some of those processes. Just a couple of screenshots. You've probably seen these in your own system. So this would be the bed optimization system. Just gives you an example. The one on the bottom would be patients in emergency departments admitted needing a bed. And so that would just show just our regional hospitals. And the one above would be all of our ICU beds in the province and what their occupancy is and what their capacity is. And having this information has proven to be extremely valuable over the last couple of years. Another example, we actually did a deeper dive because we were starting to see some patterns with diagnostic imaging and them being a barrier. And so this is province-wide from January 1st to July 31st last year of the number of days related to diagnostic imaging delays across all 9 organizations. And these two graphs, so the one on the top shows bed capacity. The one on the bottom would be the breakdown of RFD, not met, and met. So it would be not met, not RFD, not met, RFD, and met. And where we have used these is we haven't, thank God, had a major emergency in the community where we've had to respond until a few weeks ago. I'll talk about that in a second. But we've largely used the system for tabletop exercises. And we've had a couple of occasions where we've done a tabletop exercise where we actually had to evacuate a 175-bed regional hospital. And by having the system with accurate information, up to date, we were able to find beds in 24 minutes to be able to evacuate it because we knew who was in the beds, who could be somewhere else in an emergency, and be able to say to the other sites, these 10 people are coming to you, start your process of getting them out of there, And in 23 minutes, we actually were able to find all of the beds and had a plan to empty it out. And I was going to give you another example. Was it 3 weeks ago? 3 weeks ago, we had a pipe burst on the 5th floor of one of our sites in our academic health science center. And so this facility our academic health science center is an 864 bed facility in Halifax, spread over 10 buildings in 2 different campuses. And in one campus, our Victoria General site, one of the buildings was built in 1957, one of them was built in 1965, and the 1965 site is the one where we had the water leak. 5th floor, water from 5th, 4th, 3rd, 2nd, 1st. It actually went, the water, the staff were marvelous. They had the room that the flood happened, shut the door, towels under the door. They were doing everything they could to keep the water in. Water went 4 feet up the walls, ran out the window, down the outside of the building, wiped out our ICU, wiped out 50 beds in a matter of minutes. And this is the site we do multi-organ transplant, all of our high-end cancer surgeries, in one fell swoop, gone. It has had and having this system has had a profound impact in our ability to plan how we've managed it since. Because every single morning, the team for critical care in the tertiary center know every bed in the province that they can access if they have to have it, so we can plan ahead. We know every site that's got beds. It has really enabled us to work as a system to cope with that crisis. So where are we going next? Certainly, we in our implementation of the bed optimization system built in functionality for external transfers. We haven't turned it on yet because there was a little bit of a glitch that we had to fix, where people could access information that they shouldn't have. And so we're in the process of fixing that. But once it's in place, all of our interfacility transfers across the province can all happen within the system. And so if there's a patient in Halifax that needs to move to Digby, the staff on the inpatient unit in Halifax can request the bed in Digby in the system and they can see that it exists. All of our bed access is transparent, and the system will track how long it takes for them to accept the bed and then how long it takes for the transfer to happen. So we'll be moving that. We're working forward with Medworxx to create some functionality in the bed optimization system for tracking emergency patients. We have an EDIS in one of our sites. And so it's because of the fact that we have 3 different HIS systems and all of them were built with one-way communication. It's really prohibitive for us to be able to put a 2-way communication EDIS system in. The cost implications are significant, so we've made a decision to hold off on that until we upgrade our HIS system. And so because we don't have the information, we want to build that functionality in, and so we're in the process of that. As Larry said this morning, we're also working on a more enhanced ALC tracking form. We're looking at some different criteria sets. We think that these 3 probably have an impact going forward. Probably a big one for me is trying to look at a number of different strategies to get information in the hands of users. That's probably one of our biggest barriers, is to be able to get information back in a timely way. Our physicians don't want to log into the system. It's just another password they have to remember. And they want something that gets sent to them. And so trying to get information pushed to people. And we want to be able to push alerts, so when people come in the morning, they know that we're overbedded right from the beginning so that they can start to act. OPOR is an initiative that we're working, where it's a government initiative called One Patient, One Record, which is a goal of government to be able to have one health record for every individual crossing all sectors of the system, physician office for lab DI, acute care, home care, all in one system. And so we're early on in that path, but from a Medworxx perspective, it will be really nice to only have to worry about having to communicate with one versus all three of these systems. And one of our HIS systems is slated to be mothballed in the next couple of years, which creates some urgency. And I would say another area of focus for us, and this isn't really related to our use of the system, but rather our amalgamation from 10 organizations into one. We're in the process of moving into more of a programmatic structure provincially with a matrix model where the programs will operate from standard setting, policy making, budget decisions as not a centralized program, but an organization-wide program rather than geographic entities trying to determine those in silos. And we need to try and adapt to how we manage flow with that sort of a context. And also continuing our work on standardization. While we're one organization now, we still have multitudes of processes, how we manage patients through each of those facilities that we need to work on changing. And some of those are sacred cows, and will take some time for us to work through some of those cultures. And that's us in a nutshell.
Hey, Tim, great presentation. I was wondering, could you just speak to your comment about using this tool for acuity-based nursing staffing? I guess I was trying to understand exactly how you were using it from that perspective.
Is that mine? That's probably me. It's a good thing I left that down there. I'll give you some context. Particularly in our academic health science center, where one would expect the vast majority of the patients on those units would be met. What we were finding is that when the nurses did their assessments every day, the information that came back where you could look at how many MET statuses they had and the accuracy of those assessments and the ability to look at what the needs were for those patients reflected much more what was happening on the unit than the information that was coming out of their workload assessments. They were fudging the workload assessments in some ways, or they weren't doing them, and the managers were able to look at, if they pulled up their unit status and 90% of the patients were met and many of them had multiple MET needs, it really reflected the acuity and the workforce demands that likely were needed on that unit versus 3 days later that could have half of the unit not met RFD. They have found it to be really valuable in looking at whether they need to staff up sometimes on those days, and particularly in our ICUs. They really find it of quite a lot of value. They believe it more than what they did with the workload, and the nurses have more faith in it. They were actually asked at our academic center, which of these assessments do you do? And the staff response was, I'll fill this one out 9 times before I'll fill that one out once. They're committed to doing the Medworxx assessment where they didn't want to do the other.
John?
Tim, congratulations to you and your team on a phenomenal implementation. And especially that your province looked at it from a provincial point of view as well as a regional point of view. I think there's a lot of us in Ontario wish we had that type of can you tell me a little bit more about how you chose that assessment model on the midnight shift? And did you standardize the discharge planning process or the roles across the province at the same time? And I just want to make another comment. That example you gave of decanting at hospital and be able to identify beds, but I think you said 20 minutes, half hour?
It was 23 minutes.
Okay. And I don't think in Ontario we could look at that even from the original point of view. So, and my other question was, in regards to the units, I noticed it was based upon discharge units. Did you get any pushback from those units when you report back? Because, again, they could have been on multiple units.
Yeah, so the reason we went that way was actually that was some feedback from staff when we were starting through the processes of implementation. There were some things that were given that they had some input into, and there were some things they didn't. We were very transparent in our process. When we started to engage staff early on in our implementation and we started to educate them, we told them, yes, this is going to take you longer. This is how long we believe the assessments are going to take. We believe in the future, once you're used to the system and can adjust your processes, you'll have time savings later, but you're not going to have them initially. When would you find the best time to do the assessments is with this context? So we said we need to have access to up-to-date data for when we have our bed huddles and our bullet rounds and some of those sorts of things. And largely it was feedback from them that there's less going on during that night period, largely, and that they felt that that was the best time for them to do them. Some teams have made a different decision, and largely that's related to a change in their process where they've incorporated the use of the system heavily into their bullet rounds and their huddles, and they do those assessments very quickly in those processes. And so we've allowed them to make those changes as it suited them, but the cutoff time we haven't adjusted. So that's that one. As far as the discharge planner, I wish we had standardized those roles. We haven't. And I would say now that we're one organization, it's even probably a worse problem because we have some facilities, now that we're one organization and everyone can see what everyone else has. Site X may have a whole pile of resources that Site Y doesn't have any. There's huge variation, and that's probably a thing that we need to tackle in the future. Is that's that question?
And I saw that it was very good, the reports back to the units, and I know that it was based upon the discharge unit. I just wondered, because you know that in the report that patients only go to multiple units, do you get pushback from the units when you report that way?
No, and I think the reason we don't is because we give them an opportunity to provide us information back when it gets rolled up further in the organization. So it's really, this is what we think the data is telling us. Can you give us some local unit context to it? There might be something specific that happened or that was going on that resulted in some of that data, especially if their compliance was in their boots. And some of those sorts of things. So that's the kind of the purpose of giving them an opportunity to see it ahead of time. And I would say that it's a process that we're trying to perfect. It's not all 100%. Largely, they don't have a lot of feedback back. The data kind of speaks for itself unless there's a bunch of it that's wrong. I think they appreciate the fact they get the information back. And I think they appreciate knowing ahead of time what everyone else is going to see their story as before it gets seen.
Two quick questions. One is, do your frontline nurses make the patient, do they designate alternate level of care or the physician, or do you have a different group? And the other question is, what model of nursing do you use, like team nursing, primary, local care?
Last question, all of those. I would like to say that it's one system, and it's all over the map. That would be another area of standardization. I'll give you an example. In what would have been the central zone, which would have been Halifax at the time, what they do is they use in Nova Scotia, there's a co-pay sort of process, just like there is with a lot of other provinces. If an individual goes to long-term care, the patient has to pay a per per day for that care. We go back in the central zone, as an example, goes back to the day they're RFD. And so that process wouldn't necessarily be by physician order, it would be by nurse assessment. And so we would actually go back and start billing the per diem to the patient from the date that they became RFD. And in some other places it's physician order, some other places it'll be whenever they can kind of go back and attempt to find documentation that's remotely close to being able to know that they're not acute. An area that we need to do some focus on.
Can I just ask about the money? So you've got the workforce that's all spending minutes each day, data inputting. You've got a much more reliable baseline set of data. What do your organisation strategically do?
I guess probably the best answer for that is the one page I gave you with those six hospitals that have high percentage of RFD. We're now in the process of going through a provincial health services planning initiative, and we're using the data from this system to guide where. We're going through a process of, and how it started is we picked 7 streams within the system: perioperative, emergency, critical care, cancer, primary care, continuing care. I can't remember the other one. And so with that process, we're looking at what is the service that is needed by the population, and also doing a sizing siting process, using this information to determine, do we have our sites in the right place? Do they have the right bed mix? Should they be acute care? And we know that with some of the facilities we have, we can either close them or turn them into something else and have a significant impact financially on the health system.
One question. You talked about the quality of the data and the audits that you do. Who does those audits?
It varies. In some instances, it's the manager of the unit that does them. In some instances, it's nurses who are on return to work from an injury. We very much have a process that we like to get people back as quickly as we can. We don't like them on WCB at home. And so that is some of that work we actually have them do. It could vary. It might be an assignment of staff on the unit. Yeah. In some of our organizations, it's actually the patient flow lead for the site does them. It varies. And I think one of the other things that I'll add to that is some of you've met Nicole on previous years when she's been here. She actually audits the audits randomly as a kind of a second look. Yeah.